First of all, how the experience of human limitation opens us to transcendence. Second point, how faith and reason complement each other. Okay? Not oppose each other, but actually support each other. And lastly, the role of prayer in total patient care and healing. First of all, I'd like to also explain that I do this not only as a priest, but also as a lover of science. Having studied a bit of science and also having reflected a bit more regarding scientific things when I was assigned in Rome earlier in life, in 2002 to 2007, in one of the offices of the Vatican Church with Family and Life. We also had to cover not only care for the family, but also topics on life, which is basically bioethics. And so we also have to study to follow all the discussions on cloning, all the discussions on different topics. Anyway, first, the experience of human limits and openness to transcendence. Learning is a lifetime process. Science and technology have advanced a lot. Way back in history, we think of agriculture in order to survive in times of natural or man-made calamities. By the way, special hello to those in Palo. I understand it also from Tacloban. Special hello. I was in Palo actually during the Pope's visit. I was there and also experienced firsthand. Parenthesis. A Filipino priest assigned there in Rome, met the Holy Father. Actually, the Holy Father visited them. That was, I think, in August this year. And as you know, the Pope was in Palo last January. And that August, the priest told the Pope, I'm from the Philippines. And the Pope announced to everyone, I still feel wet. I still feel wet because of that experience in Palo. Okay? Anyway, learning is a lifetime process, and the medical field in particular has advanced a lot by leaps and bounds, especially in the recent decades. So think of non-invasive operations, stem cell research, surgery, drug research, genetics, etc. Of course, ethical questions also arise. Case in point, genetic screening. First of all, whether to require or not genetic screening, at least in some situations or jobs, what to do with the data, to use that data for the person's or the community's good, and sometimes even for the community's self-defense. It's a genetic screening. Ethical questions are often transported into legal guidelines. I read a book, The Ethics of Human Genetic Intervention by Peterson, Genetic Turning Points. It was published in 2001, and I think it's still very relevant. You are all specialists, which simply means that you strive to know more and more about less and less. And that is specialization, knowing more about less. And that is what you are dedicated to. I don't know if there will be ever a specialist for the left eye and for the right eye, as I would say. But the point here is that it is impossible to know everything. On the one hand, knowing more, on the one hand, progress in medicine, in technology, in science, is also, well, first of all, it would allow us to act in an easier, in a better or less riskier way. Science and technology, sorting out ethical and legal questions, field specialization. On the other hand, the very concept of progress brings with it, the very concept of learning, of knowing more, brings it with it the concept of limitation. How is it possible that we learn something? It is because we do not know it first. Before we learn something, we are ignorant of that fact, and then we learn. So it means that we were limited, and we become not limitless, but rather less limited. If we know something else, we become less limited, less limited, less limited. So the move is not from a limited to an unlimited stage, but it's always from a limited to a less limited stage. In other words, the fact that we continuously learn and will never stop learning is actually an indication of human limitation. Yes, it is an indication of human greatness, human potential, so we can do a lot. But at the same time, it indicates that yes, we can do a lot because we cannot do everything. We cannot do everything yet, or we will never be able to do everything. Again, another parenthesis, somebody tells you, you have a lot of potentials. Will you be happy or not? If somebody tells you have a great potential, maybe you'll be happy, but actually, if you are a bit philosophizing, to have a great potential means that you still lack a lot of things. you have a lot of things to learn still, because you don't know anything yet. So you have a lot of potentials. You are very promising. You can develop a lot of things because you are still underdeveloped. Sorry. Anyway, we can still do a lot, yes. Because we are still in new procedures, new drugs amaze us, but at the same time, we feel that much more has to be done. Patients, for example, patients researching on the internet could spur us to study a bit more. I hear that doctors sometimes to talk with these patients, they do their own research on the internet, so the doctors also have to see whether these researches are really valid or not. They have to also confirm their own knowledge with the knowledge of the patients from the internet. We can apply similar arguments to other fields, other realities, from medicine to physics, chemistry, ecology, etc. In fact, not only humans, but everything else is limited. Think of chimpanzees' intelligence or the fruits that could bear only up to a certain amount in a certain season. At this point, I also have to put a limit on my discussion on limits and have to go ahead a little more. What happens when we overcome a certain limit? When we overcome something, we say that we transcend. When we say that we transcend, meaning we become open to something that we have not yet faced or we have not yet known. Normally, we will be faced with another limit. For example, you try to cure a certain disease, you give drugs to cure a certain illness. You need drugs for, I don't know, for high blood, and then you get your kidney gets damaged. So things like this. So you overcome a certain limitation, but you create another wall, another limitation. Resistant strains, nosocomial infections, and so on. Transcendence is contrasted with immanence in philosophical terms. To put it simply, what is immanent is what we experience or can experience: our life, our feelings, our health, parts of our body, and so on. What is close to us, what is in direct contact with us. In Latin, in plus manere, to remain, for example, also comes from the same root word, manere, to maintain something, to remain in something. Transcendence, on the other hand, which we become open to when we discover our limitations. Transcendence comes from trans, or across, and scandere, to climb. Okay? When we transcend something, we climb. We climb beyond something, across something. We go over, we go beyond something. We said earlier that the experience of progress, of learning, is at the same time an experience of human limitation. What we can say now is that the experience of limitation opens us the question of transcendence, of something beyond. Will we continue to climb over a wall and see another wall continuously forever, and there is nothing else than these walls? Or is there something beyond these limits? Okay? Will there be eventually a big wall that we can no longer cross? And will there be something beyond that? And these are precisely the questions that philosophers have been asking ever since time immemorial. And of course, we cannot really solve during this 30 minutes or during this day. And these questions are even made more complicated by succeeding questions. If there is nothing or something beyond our existence, the meaning of our life, our relationships, our professions, our striving to go beyond what we are limited. So the big question eventually would be, is life really worth living? Living is the ultimate question, especially for those involved with end-of-life care and making end-of-life decisions. Maybe the fact that we are here seems to suggest that yes, life is worth living. Maybe life is truly worth living. And we can ask these questions for ourselves, we can ask these questions for our patients, or we can ask these questions maybe when we also, at one point in our life, are patients. I would like to propose at this point that human limits, our experience will bring us to think that indeed, for us to exist, there is something or someone who is at least less limited than ourselves. Someone who created us, someone to whom we can turn to. And now I'm going a little bit more into what prayer is. Turning to someone, or at least to something, for those we belong to different religions, but at least there might be some common points. Someone greater than us, something greater than us, that created us, that should be unlimited, or at least less limited than us. I do not try to forward the idea of any spirituality or religion in particular, but rather just this idea. Of course, personally, I have my convictions as a Catholic priest, but rather I would just like to point out that the idea is universal, of a universal, omnipotent, all-powerful creator is someone that is way beyond us. Is not is an idea that is not foreign to reason. Not foreign to reason. And now I'd like to go to the second point, how faith and reason actually complement each other. This is necessary to see the relationship between faith and reason, because some might object that faith doesn't need reason, or reason cannot live with faith. Some might say that faith, which is necessary in prayer, seems even contrary to reason. And therefore, we might be simply discussing a topic that is in the first place irrelevant to medical care, which medical care following a scientific approach is heavily based on reason. Take the case of a very famous discussion on creation and what do they usually contrast with creation and evolution. Creation and evolution, they always show that as an example. Some maintain that the universe was created by God. Some maintain that the universe started with a Big Bang and eventually continued through evolution. Through the evolution of species, through what Darwin was describing. Or, the question could also be, do they necessarily have to be opposed? Does creation have to be opposed? Different or incompatible with evolution, with the Big Bang. I would say that, well, from my scientific background, I would say that they're not really opposing each other. It's not really incompatible. Creation and evolution, they're not really incompatible, because creation talks about the beginning, evolution will talk about the progress. And this is actually the focus of science. Science focuses on the development. Science focuses on progress. On the other hand, faith would deal a little more on the beginning and on the end, on the purpose. Science, biology, to describe what is happening with the cells, with the organism, and so on. But biology would find it difficult to explain how come all this began, how all this began. Okay, so my point here is simply that faith and reason complement each other. Faith and reason do not have to contradict each other. And there has been a saying in the olden times, faith seeking understanding. Faith seeking understanding. So if we want to grow in faith, we also have to try to understand more and more. Faith is not a mere assent to some statements, but involves deepening in one's understanding. And that is why it's a personal experience. In Rome, where I am assigned now at the College of Filipino, we have our priests doing further studies. And these priests have already been ordained, meaning they have done their studies in philosophy, which is a 4-year course, and theology, another 4 or 5 years, and they do further studies. Those specializing in scriptures, in the Bible, they have to do 4 years of the masteral studies. Why 4 years? For their first year, they only have 2 subjects. What are these 2 subjects? Hebrew and Greek. So they have to study Hebrew and Greek for 1 year. Why? Because for their second year, the Bible that they study is not the English Bible, it's not the Italian Bible, not even the Latin Bible. They study the Old Testament in Hebrew, and they hold the Old Testament in Greek. And so we have to study those original languages because we have underneath all those pages of the Bible. Of course, you can simply read the Bible and say, okay, I believe. It would be much better if you have to deepen a little more and try to see all the history there, all the cultures, all the movements beneath those pages. You might be familiar with Francis Collins. Does the name sound familiar? Francis Collins? Francis Collins. Yes, so he was involved with the Human Genome Project. He led the project from 1993 to 2008. They succeeded in mapping the human genetic makeup much earlier than they thought possible. What does he say? Collins says that science is the only reliable way to understand the natural world, and its tools, when properly utilized, can generate profound insights into material existence. But science is powerless to answer questions such as, why did the universe come into being? And this is what I was saying before. Yes, the scientists can explain the Big Bang, the universe expanding, collapsing, and so on. But as he says, the meaning, why did the universe come into being? What is the meaning of human existence? What happens after we die? All this. One of the strongest motivations of humankind is to seek answers to profound questions. And we need to bring all the power of both scientific and spiritual perspectives to bear on understanding what is both seen and unseen. The goal of this book, he says, in this book, The Language of God, a scientist presents evidence for belief. The goal of this book is to explore a pathway towards a sober and intellectually honest integration of his views. Indeed, science can describe existing objects, but the scientists cannot really determine the beginning of the series of processes. So now, let us put this into medical care. As said in the introduction, I was also 5 years with the Makati Medical Center by the Ethics Committee. So every Tuesday we would meet, every Tuesday, and every last Tuesday of the month we would have the grand rounds in bioethics. So all those under training were required to attend those bioethics weekly presentations. Anyway, in medical care, as doctors, you are trained to save lives. You are trained to keep the patient as healthy as possible. And when the dying process sets in, you are also trained to try to hinder that dying process. And doctors sometimes will look at death as a defeat, as a sign of that you failed, that you were not successful in treating these patients. And you go into extraordinary measures. You try to go into extraordinary measures. Oh, there's still a pain, you can still insert a needle, another tube, another catheter, another, just to save the life of the patients. And at the same time, you might actually be asking yourselves, are these extraordinary measures worth it? Are these extraordinary measures keeping the patient alive? Keeping the patient alive? Or are they delaying the patient's death? Well, they mean the same thing, keeping the patient alive or delaying the patient's death. And they refer to the same thing, but from a different angle. Is the patient actually alive in the sense of being healthy, in the sense of having of being still in his prime, or is the patient actually dying? Is the patient actually dying? So these are two different angles of the same reality. And advise decisions to be facilitated if faith is taken into account. If faith is taken into account. Because you always use reason, trying to heal, to keep the patient alive. But the question lingers, the question is there. So maybe reason cannot or science cannot actually answer those questions, and this is where faith would come in. As we all know, dying is a process, death is an event. And not taking extraordinary measures could also be a sign of acceptance, not only of one's limitation, but also of the fact of transcendence. And there is a point when we all have to accept death, when we all have to think a little of what might be beyond this earthly life. And withholding or withdrawing extraordinary measures, in some cases, far from killing a patient, is actually simply allowing a dying person to actually die. So there's a big difference. When you withhold a treatment, when you withdraw a treatment that you already started, at times, of course, it still depends on the situation of the patient, but at times it could mean not killing the patient, but simply allowing the dying patient to actually die. So these are things that we can always consider. And the faith of the doctor and other healthcare workers, the faith of the patient and of the patient's family would give an added perspective to sickness and medical care. Although we have to give all the importance we can to this life, through faith we also can go beyond. We transcend life's limitations and continue to find meaning beyond the apparent defeat in the struggle for health. Third point, last point, the role of prayer in total patient care and healing. In the previous talk, I think Dr. Kafi allowed us to sleep. In this talk, I will also allow you to pray. I'm just joking, but just to show you a little more, the role of prayer in total patient care and healing. To pray means to turn our thoughts to something or someone beyond us, which, if it is something, or who, if it is someone, has some power that could change the course of events. For example, of a disease. Some patients, families, and doctors believe in God, some do not. Okay, so the purpose of my discussion now, presentation, is for those who do believe in God, then then prayer is something natural, and the following considerations will hopefully confirm their turning to prayer. On the other hand, for those who do not believe in God, far from attempting to make them believe, at least I hope the following considerations would simply make them understand a bit more the perspective of those who do believe in God and prayer. Sometimes a distinction is made between being spiritual and being religious. Being spiritual means turning to something or someone supernatural or divine beyond what is merely human to receive some help. So spiritual is a little more generic. To be religious means to follow a certain, the teachings of a certain institutionalized religion. From time immemorial, different forms of spirituality and religiosity abound in practically all cultures all over the world. So sociologists, many sociologists will say that spirituality, religiosity actually forms part of human nature. A part of human nature is to be spiritual. In the same way that sociologists would say that part of human nature is to be sociable, to relate with each other, and to be rational is also part of human nature. So to be spiritual could also be part of human nature. In an interview with Medscape and Anthony Cannon last 2015, he was studying on the effects of spirituality and religiosity on quality of life, at least quality of life as perceived by the patient. He explains that, now I quote, there is an abundance of emerging evidence that patients desire spirituality and religiosity to be addressed and incorporated alongside the medical treatments for their cancer. Addressing spirituality and religiosity may not change the way we treat illnesses, but it fundamentally changes the way we engage patients. Okay, so patients themselves, they want to deal with these questions. The mere fact that a certain patient desires to talk about spiritual things could be a question for us, could be a question for doctors. If the patient wants to talk about spiritual things, then maybe that is something good for the patient. Because if he is the one who initiates, for example, he mentions or he just out of the blue he talks about spiritual things, then it could be something that could be helpful for the patient. In end-of-life situations especially, it is but natural for the patient to ask what would come after death. So the patient is dying, the patient knows that he or she will die within a few days, a few months, a few weeks. Then the patient would naturally ask what would happen after I die. Of course, we have no answer that we have to, but at least the patient talking with others, with the family, and even with the healthcare practitioners would help me. One should not impose, of course, a certain spiritual or religious belief on others. In Brazil, they say if you don't want to get into a fight, don't talk about politics, religion, and soccer. And soccer, because you'll end up fighting from another team. But if the doctor and patient both hold the same beliefs, then there is no problem at all, I would say. The patient will even be most receptive to talk about spiritual or religious matters. What about the doctor? So far, we have talked about the patient. Many patients would like to talk about spiritual and religious topics. What about the doctor? Is he or she ready to talk about these matters? In another study, this time in the Journal of Pain Symptom Management, the title is Nurse and Physician Barriers to Spiritual Care Provision at the End of Life. It reported that most nurses and physicians want to provide spiritual care within the setting of terminal illness. 74% of nurses and 60% of physicians. However, 40% of nurses and physicians provide spiritual care less often than they would like to. Okay, so here the study says that, well, even doctors and nurses, they also want to provide spiritual care. Why? Because that is what the patient needs. Also, if the request comes from the patient, if the patient initiates such communication, then many physicians and nurses would also like to correspond, would also like to talk about these matters. But there are barriers. And what are these barriers? They include lack of private space, lack of time, inadequate training, belief that spiritual care is not part of the medical profession's role and is better provided by others, and worry that spiritual care is inappropriate given the power inequality between the patient and the doctor. At the same time, this report notes that, I quote, the provision of spiritual care is a strong recommendation by the World Health Organization, the National Consensus Project, the Joint Commission, and many other organizations. Okay, so imagine the World Health Organization itself recommending provision of spiritual care. And I hope this conclusion was not based on false positive high medical journal, high impact medical journals mentioned by Dr. Davis. So, provision of spiritual care. It is wanted by many patients, also many doctors and nurses want it, and I would say if there is no conflict then, why not? If that will also help the patient. Because we always emphasize holistic medical care. Otherwise, we will end up, the doctors would end up being like mechanics. One of the first lessons that we have in medical school, one of the professors at the he was saying that, well, doctors are not just like mechanics. We are not fixing cars, we are not fixing machines. We are actually dealing with persons. We are not dealing with bodies, simply bodies, but with persons. And the last quote in another study, Research Priorities in Spiritual Care, this sort of describes that spiritual distress, including meaninglessness and hopelessness, is common in persons with advanced disease. Spiritual care is a core component of palliative care, yet it is often neglected by healthcare professionals owing to the dearth of robust evidence to guide practice. So here it says that spiritual care, yes, is part of palliative care, but the problem is we actually lack studies. So this article is in a way also a call for more studies on how best to deliver spiritual care. Okay, so knowing that, but assuming or accepting that spiritual care is needed, then how is this spiritual care delivered? And this still lacks a lot of studies. Conclusion, just to sum up everything. Prayer is the lifting up of our heart and mind to God. Spirituality or religiosity will always include at least some form of meditation, adoration, petition, atonement, or thanksgiving, which are expressions of prayer. First, the patient's capacities to resist diseases and death are pushed to their limits, and appeals for help are directed to all those involved in holistic care. The medical personnel, family, and the chaplain and other personal care workers. The question of what comes after death appears. For us who are religious, those who follow a certain religion, those who are spiritual, prayers work wonders. We pray and we hope for a cure. If the cure takes place, we thank God for it. If it does not take place, we understand that maybe God wants us to be more consistent or God has other plans. What is the mechanism for the cure if it happens? Scientifically, we do not know exactly. We cannot make a study on how come the cure came about. But it could be, we could say, the result of both divine medical intervention and divine intervention. As the saying goes, we do our best and God will do the rest. True prayer does not follow the logic of empirical sciences, but what the praying person seeks for is beyond what the empirical sciences will offer. The meaning of life, joy, relations with others, and so on, these are not provided by the empirical sciences. Faith and science do not have to contradict each other. Both patients and doctors and the patient's families often wish to be engaged in holistic care beyond what medical procedures can offer. While there should be due respect for each other's beliefs, there need not be inhibitions when it comes to shared beliefs, or when one wishes to know more about the other's views. If all parties are convinced regarding the power of prayer, then engaging in prayer would be only good to the patient. Thank you very much.
Thank you very much, Father Greg. Is there any question from our satellite locations? How about from the room?
I have a question, Father. This is a question by our president, Joji Quitos, but he's still to the Paris High School. He wants to know if this lecture will have a Sunday Mass.
Not really, because today is a Tuesday.
My question is, what is the right prayer that we should give so that we can play golf tomorrow without rain?
Great. Santa Clara is because the egg white in Spanish is called Clara. Clara is the egg. So it also means clear skies. That's why they offer eggs to Santa Clara. So that's the reason.
In your experience, what kinds of questions are most asked of you from physicians regarding bioethics? What's the most challenging for physicians that you think of that they need help with?
Regarding bioethic topics, first I'd like to make another parenthesis. Actually, the role of the bioethics committee, for bioethics in general, is not it's not a tribunal. But some would think that you go to the bioethics committee because you have a difficult case, you want the bioethics committee to decide, okay, shall I pull the plug or not? Okay? No, it's actually the third role of the bioethics committee. The first role is education. So at least there in Makati, I was involved in the bioethics committee and later with Cardinal Santos. Education means to try to open all these considerations to the medical professional so that when the time comes for difficult questions, the doctor will be able to decide by himself. He doesn't have to go to the bioethics committee to ask, shall I pull the plug or not? Why? Because he himself would not know whether it is an extraordinary procedure or not. If it's an extraordinary procedure, then, well, still case to case, then maybe the plug could be pulled. Another question is, who will pull the plug? Who will pull the plug? The doctor? Can the doctor order the nurse to pull the plug? Shall it be the spouse to pull the plug? But please, not the priest. Not ask the priest to pull the plug. Otherwise, headline, priest kills patient. Okay, so anyway, these questions. So first, education. Second is to come up with policies. So repetitive cases, for example, you could already come up with policies so that you could simply refer to those policies. And third is decision making. So if the doctor finds it difficult to decide, he looks at the policies and he doesn't find anything, then he could go to the bioethics. Okay, so the questions end of life decisions. Confidentiality. For example, for dermatologists, the husband has STD, sexually transmitted disease, he could possibly infect the wife. Should you tell the wife or not?
One for the stage. One for the stage.
Secret. Or for example, an epileptic patient who is a bus driver. Okay, a bus driver. So epileptic patient, should the doctor tell the company or not? Or what I mentioned also, the genetic screening. Should you require genetic screening in certain cases or not? Or simply HIV screening. Or the surgeon who has HIV, should he continue to practice or not? So all these different questions. The answers I cannot give in 2 minutes. That's why I would encourage you also to hold bioethics sessions. Because that will facilitate your work outcome. Bioethics will facilitate a lot of decision making. So it's not to judge you did wrong, you did well. No, bioethics is to facilitate decision making. And also to guide the family, also the role of the family. And you also go into legalities, that's why you have to approach bioethics from the medical perspective, from the legal perspective, and also from the ethical, philosophical, religious perspective.